I'll be talking about Rotem for next 15-20 minutes. So lately in last couple of years this has been a very common question, and in our CBS and CCS domain we consciously have made effort that we'll be asking about this domain quite frequently, because rest assured you will get one question either in the CBS or CCS, if not more than one question from the Rotem or a TEG. So Rotem is a short form of rotational thromboelastometry, which is a point of care coagulation monitoring. And in this session, I'll be talking about a little bit of introduction about Rotem, principle, mechanism, and how it works, and understand the channels of Rotem, and then a few cases to interpret the results of Rotem. Now, Rotem, the basic core purpose of using Rotem clinically is to optimize blood product transfusion. It enables targeted replacement of the deficient components rather than giving just the whole blood or some empirical transfusion. So it gives you a basis and look at or aims at correcting a particular abnormality in the coagulation rather than holistically giving a lot of blood product. The effect of that is it reduces the transfusion associated complications simply by reducing the number of transfusion, and also it reduces the risk of DRALI or TACO or immune modulation that can happen due to unnecessary excessive transfusion. Um, it looks at three basic stages of clot, or three basic stages of coagulation, which is time for formation of a clot, clot strength, and how it is broken down. The best thing is that you get a report in front of you, or part of the report in front of you, in 5 to 10 minutes, and you can start acting on it rather than waiting for a routine coagulation test that you send to the laboratory and wait for half an hour to 1 hour at least. Um, Now the question is, you look at a curve that is there in the screen on the left hand corner, but how is it generated? So there is a very simple principle to it. You add whole blood to a cuvette, and a pin is suspended inside that sample. The pin rotates gently back and forth. Initially, the blood is liquid and there is no resistance, but as clotting happens, fibrin and platelets bind to the pin and restrict its movement. Thereby, the depiction on the picture becomes less and less, or changes. Now, increasing clot strength further limits the pin movement, thereby it produces a particular type of curve. And the changes in the curve compared to a standard curve and the measurements on the curve reflects the clot firmness. So that's the whole principle of Rotem, how this curve is generated from this pin that rotates inside the blood. Now, depending on how firm and how quickly the clot is formed, the character of that curve changes. And we look at that in a pictorial manner with the numbers beside them showing different parts of the coagulation. Now we know the cellular model of coagulation includes three phases, that is clot initiation, amplification, and propagation. And through this three phases, the coagulation factors get activated and forms a clot which stops bleeding. Now, at different stages of this process, initiation, amplification, and propagation, different factors come into play. For example, in initiation is what do you call it, is initiated by the tissue factor, and then the tissue factor exposed to blood activates factor 7, which starts to go into the next phase, the amplification phase and propagation phase. Now, I'm talking about these phases because particular parameters in Rotem look at different phases and you correct the abnormality based on that. Um, we have read the coagulation as intrinsic and extrinsic pathway, and they combine, uh, and the end result is formation of a fibrinogen and then a fibrin clot. They look separate on this paper, but they are very interrelated process, and that's how the cellular mechanism is slightly different from the traditional coagulation studies that we have known about. Um, but both the cellular mechanism and the intrinsic and extrinsic pathway at some stage determines how the coagulation is interpreted in the rotem per se. The most important part of the all of this coagulation factor, what I think, is fibrinogen, which is called as the factor 1, because it forms 95% of the clotting factors by mass. The normal level is 2 to 4 grams per liter. It depletes very quickly because this is the first factor to fall during a coagulation process, and it depletes very quickly. And in different studies, you probably know about multiple randomized trial where fibrinogen is replaced empirically or based on a rotem has led to correction of or rapid correction of coagulopathy. So this is one of the most important factor that is being quantified by the rotem. And in pregnancy, which can be a question, one of the case scenarios is on that. So in pregnancy, fibrinogen level are higher, usually double what it is, so 2 to 6. And the critical threshold for obstetric bleeding, we think when the fibrinogen level is less than 2 gram, that is the critical threshold, and we aim for a fibrinogen level of 2 grams in an obstetric patient. Now, I'm talking about fibrinogen because that's the viva they usually ask about. What is the form of fibrinogen you use and what is the benefit of one form from the other form? So there are at least 4 different ways that fibrinogen comes into clinical practice. One is fibrinogen concentrate, which is pulled from human plasma and stored as a powder at room temperature, and then it is reconstituted with a supplied sterile water. It provides about 20 gram per liter or 1 gram of every 50 ml. That's the fibrinogen that you get from the fibrinogen concentrate. The second preparation of fibrinogen is cryoprecipitated, which is very commonly used. Again, it is a controlled thaw of plasma to precipitate high molecular weight protein like factor 8, von Willebrand's factor, fibrinogen, and it is resuspended in 30 ml of plasma. Again, the concentration is less compared to fibrinogen concentrate. It's less than half of what you get in the fibrinogen concentrate, but still it is one of the major product where you get fibrinogen clinically. Slightly better is the apheresis cryoprecipitate, which has a higher concentration, almost equal to the fibrinogen concentrate, which is 18 gram per liter. And the least efficient one is fresh frozen plasma, where you get only 2 gram of fibrinogen per liter of fresh frozen plasma. So if somebody asks what is your preference of product that you want to give to replace fibrinogen, I would say if it is an acutely, or the depends on the urgency. If the patient is hemodynamically unstable and bleeding is the cause of that and you want to correct it within minutes, that will be fibrinogen concentrate, because you don't have to do anything, you just reconstitute in the plasma, reconstitute in the water and just give it. If you have time, you can wait for half an hour, then you can ask for cryoprecipitate coming from a blood bank and you thaw it and give it. Again, the delay is about half an hour to 1 hour. Any of those, apheresis or apheresis cryoprecipitate or usual cryoprecipitate, the second choice. But if you don't have anything, then fresh frozen plasma has a very minimal amount of fibrinogen in it, but can be used. Now going to the prerequisite for treating a patient who has some abnormality in the rotem. But often clinically we forget about important things that needs to be optimized before thinking of giving any product to the patient who has some coagulation abnormalities. Patients need to be euthermic because hypothermic patients tend to bleed more and whatever you give will not work. The Rotem doesn't show a calcium level, so hypocalcemia needs to be corrected because that's you cannot see on a Rotem what's the calcium or effect of the calcium. So calcium has to be corrected to normal before thinking or interpreting a Rotem. If the patient is on some anticoagulation, oral anticoagulation, then Rotem is not helpful. Whether they are on a NOAC, in that case, you may find a normal Rotem, but the patient may be bleeding. Okay. Also, patients who are on a antiplatelet or platelet inhibitors such as aspirin, clopidogrel, or GP2B3A inhibitors, in those cases, the effect of Rotem is not, or their effect you cannot interpret in the Rotem. So if they are the bleeding is because of antiplatelet, it will not be evident on a Rotem. Plus, diseases such as von Willebrand factor deficiency or uremia, which inhibit the platelet function per se, may not be uh, reflective in a Rotem. You may not find the effect of these diseases on a Rotem. And platelet function or platelet dysfunction cannot be interpreted by a Rotem. You cannot interpret fully whether the platelet have dysfunction or not. So there are some limitation to Rotem where if these are the coexisting thing, you will not find the exact pathology. Right? That was a bit of a introduction about Rotem and what are the clinical scenarios. Now we have two type of cartridges in the Rotem. Um, Basically, you run 5 channels. If you have a patient who is heparinized, suppose someone is on a CP bypass undergoing a cardiac surgery, then we use a cartridge which is called as complete plus hep cartridge, where you have a heptem which nullifies the effect of heparin and then gives you a result. So whatever you get is not because of heparin. And the usual complete cartridge which has 4 channels in it, like the fiptem, xtem, intem, and eptem. So these are abbreviated name looking at that type of effect. For example, fiptem is fibrinogen. In this case, you assess the fibrinogen function in the blood. In xtem, you assess the extrinsic pathway function of the blood. In intem, you assess the intrinsic pathway function of the blood. And in eptem, which is eprotonin, you look at the fibrinolysis, if there is a fibrinolysis there in the blood or not. So these abbreviated name suggest what type of assessment that you are looking for. Okay. Similarly, heptem, whether the changes are because of heparin or not, you can find out with the heptem channel. Okay. Now, how the channels are or how the information is derived from the channels. In xtem, you have a activator or additive added to the blood, which is the recombinant tissue factor, which activates your extrinsic pathway, and you assess the combined effect of fibrinogen and platelet, which contribute to the extrinsic pathway. So in extrinsic pathway, you look at the effect of fibrinogen and platelet combinedly. Okay. So it is a screening channel. Abnormal clotting time indicates factor deficiency or extrinsic pathway deficiency. The fiptem looks at the fibrinogen. In this case, into the xtem channel, you add a platelet inhibitor so that you take away the function of the platelet, and whatever is happening is because of only fibrinogen. So it gives isolated fibrinogen contribution because the platelets are already being neutralized by the cytocalcin D. So this is added to the channel to take away the platelet effect, and whatever effect you see is because of the fibrinogen. So fiptem, you get a functional assessment of the fibrinogen level, usually we take a 50 at 5 minute or amplitude at 5 minute less than 12 is abnormal. That means the patient has some fibrinogen deficiency and you need to give some fibrinogen, right? The third channel is INTEM, or as the name suggests, intrinsic pathway. Looking at it again, it is you add a contact activator so that the intrinsic pathway is activated. It looks at factors such as factor 8, 9, 11 and 12, and basically the role of INTEM is to compare INTEM with HEPTEM and to see if there is a residual effect of heparin is there or not. That means if abnormal INTEM gets corrected in HEPTEM, that means the effect is because of heparin. Because in HEPTEM we take away heparin, we add some heparinase, we take away the heparin effect. So whatever effect is there is because of the intrinsic pathway factors. And if it is normalizes in HEPTEM, that means the abnormality that we saw in INTEM is because of heparin, because it is normalized now. So HEPTEM looks at heparin effect. And then EPTEM is looking at when you add to the extrinsic or extem channel, you add aprotinin to neutralize the fibrinolysis. And if there is an abnormality, that means that you need to add some more antifibrinolytic agents. So fibrinolysis is detected in EPTEM. Okay. What you do, you look at the extem and EPTEM. If both are same, then there is no fibrinolysis. But if extem is prolonged and EPTEM is normal, that means there is some issue with fibrinolysis. Okay. So key diagnostic pair, you look at two channels together. So extem and fiftem. Fiftem looks at fibrinogen, extem looks at fibrinogen plus platelet. So what happens? The difference between A5 between extem and fiftem, if it is substantial, like 20-25, that means you have enough platelet function there, both are working. But suppose the fiftem A5 is 12 and extem A5 is 15 or 20, the difference is 8. That means on top of 12 of fibrinogen effect, you only have 8 of platelet effect, which is less. So that means the patient needs platelets. So extem and fiftem gives you the combined effect of platelet and fibrinogen. In fiftem, you only see fibrinogen effect, and in extem, you see the difference between the extem A5 and fiftem A5. And if the difference is low, that means there is less platelet, you need to give platelet. If the difference is substantial, that means the platelets are there, they're working fine. Okay, I talked about fibrinolysis. So extem and eptem are compared. If eptem maximum clot MCF is more than extem MCF, that means there is a lysis present. Okay, maximum clot formation. And then I talked about intem and heptem. If the abnormality is corrected in heptem, that means you have heparin that is causing the bleeding. It will be a bit obvious when we talk about the clinical cases, right? Now, these are the channels that you look for, and these are the parameter you look for. So A5, A10, that is clot firmness at 5 minute and 10 minute in each of the channel. In fiftem, A5 gives you the fibrinogen level. In extem A5, it gives you the combined effect of fibrinogen plus platelet. Okay, it comes within 5 minutes, so this is the early thing that you look for. Normal is if fiftem A5 is 12 to 25, that means enough fibrinogen is there. If extem A5 is 32 to 52, that means there is enough platelet plus fibrinogen are there, right? So within 5 minutes, you will get these numbers. The second thing you will look for a maximum clot firmness, where if the clot firmness is somewhere between 56 to 72, that in the extem, that means there is enough fibrinogen and platelet and the clot is strong. Okay, low clot firmness means either it is a defect of the fibrinogen or platelet that you see in the extem. So whatever abnormality you see in the extreme is because of platelet or fibrinogen, right? Now the third thing you look for ML or maximal lysis or maximal clot lysis. That is percentage reduction in amplitude from the maximum clot firmness. So how much it has reduced from MCF to see the what percentage decrease. So less than 15% or 12% is taken as normal. If there is more than 15%, then there is significant fibrinolysis and you give tranexamic acid for the same. Okay. So these are the usual reference numbers for the Rotem, where you look at the clotting time, normal in the XTEM channel, as this is a screening channel we said. So clotting time 38 to 79 normal. If it is high, then there is a factor deficiency. Firmness, again, clot formation time is 34 to 159 second. Again, if it is deranged, then there is low fibrinogen and platelet. A5, if it is low, low fibrinogen in the FIBTEM, if it is low, and A5 is low in the XTEM, that means both fibrinogen and platelet may be low. Then maximal clot firmness, again platelet and fibrinogen it looks for, and lysis, if it is more than 15%, then there is ongoing fibrinolysis. Okay. Uh, Now clotting time. So the clotting time is this bit where it starts to generate the clot. Okay. Time from the test until 2 millimeter amplitude is detected reflects coagulation factor activity initiation phase. We talked about the initiation phase. That's what it looks for. Okay. And usual clotting time in the XTEM is 38 to 80 seconds. Clot formation time. So time from 2 millimeter to 20 millimeter amplitude. So this is 2 millimeter amplitude 2. If I make it a little bit bigger. So somewhere is here 2 millimeter amplitude to 20 millimeter amplitude. This is the clot formation time. Okay. So it reflects the fibrinogen level and platelet function again in the XTEM. And normal is 34 to 159. Now something called as the alpha angle, which is the tangent at 2 millimeter amplitude. So at 2 millimeter amplitude, you put a tangent, right? Reflects the rate of clot formation. If the angle is steeper, that means the clot formation is faster, usually more than 60 degrees. That's what we look for. Okay. Now the Rotem doesn't talk about that. You have to draw it manually on the screen. Usually it doesn't come, but somebody may ask about alpha angle. So you put an angle there. If it is like 45 degrees, that means clot formation is slow. If it is more than 60 degrees, that means it is good. Okay. All right. Now, clinical application. We'll talk about 5 example and then we'll wrap up. Okay. Now, you need to know the steps to look at the Rotem. So in the exam, you will get a screenshot of the 4 channels and there may be some numbers highlighted which are usually either bold or in color, and then you have to interpret a result. How do you go about it? So first thing, you look at the heparin excess, is whether there is a heptem channel or not, right? That means if there is a heptem channel, that means the patient is on heparin. Possibly it is a post cardiac surgery bypass heptem, bypass Rotem that is being shown to you. And if the coagulation gets normalized in heptem channel, but it is abnormal in all the other channels, that means the whatever abnormality is there is because of heparin. Okay, that's the first thing you look for. If that is the case, you treat it with protamine. Suppose that's not the case, the second thing that you look for is the FIBTEM. So FIBTEM A5 is the number you look for. If the A5 is less than or equal to 9 millimeter, that means you have a fibrinogen deficiency. You have to treat the patient with fibrinogen. The first thing you see fibrinogen because this is the factor 1, and if there is a deficiency of fibrinogen, most of the channels will look abnormal And if you start looking at other channels, then you'll be confused. So first look for the heparin excess or heptem. If it is not a heparinized blood, then you look for the fibrinogen 5-tem channel. If the 5-tem is abnormal, less than 9, and for obstetric patient, if it is less than 11, then you know there is a fibrinogen deficiency and you have to correct the fibrinogen by giving either cryoprecipitate or fibrinogen concentrate, depending on how you practice. Now, the third thing, okay, that's not the cause. Then what you do is to look for the extem. If you have a fibrinogen of 9 millimeter or more, normal in 5-tem, but in extem the A5 is 35 or less, like the difference is 25 or less, that means you have issue with platelet, right? If both are low, like 5-tem A5 is low and extem A5 is less than 25, it is a combined problem. Even if the fibrinogen is high or normal, but the extem is low, that means it is a problem of the platelet. Okay, you give the platelet. So third thing you look for is the extem. The fourth thing then you look for is the 5-tem A5 and extem CT clotting time, right? If the clotting time is high in the extrinsic pathway or extem, if it is more than 90 seconds with a normal fibrinogen, then the problem is in coagulation factor and you have to give prothrombin next to these patients. That means extem CT is prolonged because of something, but the fibrinogen are normal. That means this is because of coagulation factor and not because of fibrinogen. Okay. The last thing you look for the clot lysis. If it is more than 12%, in my setup we look at 5%, but if it is more than 12%, then you know that there is a ongoing fibrinolysis and you need to give or correct the fibrinolysis. So this is the usual step that we follow in clinical practice to look at a Rotem or interpret a Rotem curve. Okay. Now let's look at some example. For example, this one. Okay. This is a patient where you have 4 channels and there is no heptem. The patient is not on heparin. So as you can see, 5-tem, intem, extem, and eptem. The first thing you see is the 5-tem A5 here. It is 15, which is normal. Okay. Now the second thing, so A5 in here in the extem is 36. So the difference is 21, which we think is probably okay. The platelet numbers are fine because this is solely fibrinogen and this is fibrinogen plus the platelet. So the difference is how much? 21. So 20 or above is okay. There is some or good platelet function along with good fibrinogen function. But what's happening here? On top of this, there is derangement of clotting time, which is evident in extem and also in intem and also in eptem. That means clotting time is deranged in spite of a normal fibrinogen and possibly a normal platelet. So what is the problem? How do you treat it? Any takers for this? So you have normal platelet, normal fibrinogen, but abnormal clotting time. What do you do? Correct. Someone has told FFP. All right. That's correct. Pretty easy, isn't it? So let's talk about a little bit more in detail. So you know that A5 is 15, clot formation is 18, which is normal. So adequate fibrinogen level and fibrin-based clot strength is adequate. Let me make it a little bit bigger for you guys to have a see. Extem CT is prolonged. Again, extem A5 is 36 and then clot formness is pretty good. So normal clot strength despite prolonged CT, clot quality is preserved once formed. So good clot quality, but the clotting time is prolonged. So that means there is a problem with clotting factor. Clot lysis is 0%, so no issue with fibrinolysis. So what will you do is to give isolated prolongation clotting time with preserved clot strength consistent with mild coagulation factor deficiency, or it may be due to anticoagulant effect. So fibrinogen and platelet function are adequate. You may need to give some FFPs. Somebody told it correctly. Now let's see the second one. Anyone want to talk about this? I will make it a little bit bigger again. So again, this doesn't have a heparin channel, so it's a normal patient who is not heparinized. Fibtem, Xtem, Intem, and Eptem. Anyone who wants to give a try? All right, what's happening here? A5 is 7. On the Fibtem, A5 is 7, which should be ideally 9 or more than 9. So 7 is low. Okay, that means you have a fibrinogen deficiency, right? Now what I said, the next step is to go to the Xtem. Xtem, here the A5 is 12. So what's the difference? 12 to 7 is 5. So along with the fibrinogen, there is a deficiency of platelets. So both fibrinogen and platelets are deficient. So you have that initial thing sorted, right? So the patient needs fibrinogen and platelet. This is the first thing, because if you don't give fibrinogen, the rest of the interpretation is no point, because the starting point of factor 1 has not been corrected and we are jumping to other factors to see. Once you do fibrinogen and platelet, surprisingly rest of the clotting will be corrected. So first thing is to do that. Okay, what other abnormalities we have? See, the clotting time in Xtem is prolonged. There may be some associated coagulation factor deficiency, but we cannot say that unless we correct the fibrinogen and the platelet. Okay. Now, clot formness is pretty low. So that means this is the effect of fibrinogen and platelet. So low clot formness. And clot formation time is pretty prolonged. Again, it is a combined effect of platelet and your fibrinogen. So all of that shows that your platelet and fibrinogen are low. That needs to be corrected. Now the next thing you see the clot lysis. That's 0%, 1%. So that's pretty normal. So there is no issue with fibrinolysis. So what will you do? You will give platelet and fibrinogen to this patient. Okay. So again, analysis, 50 is 7 and um, clot formness is only 10. So low fibrinogen level, treat with fibrinogen. This is, you can give either cryo or fibrinogen concentrate. Extem CT is 105. Again, there is delayed clot formation or initiation. You may consider prothrombin complex and fresh frozen plasma, because I said the clotting time is a bit prolonged, but sometimes only fibrinogen and platelet can fix all these things. Clot firmness is pretty low. So again, there is a problem with platelets and fibrinogen. Intensity is high again because the intrinsic pathway is also deranged, so may need some FFPs in that case. And the lysis is only 0 to 1%, so no evidence of fibrinolysis. Okay. Also, you look at the eptem and extem. So eptem and extem, both of them are looking same. That means there is no fibrinolysis. Otherwise, they will look different. If there is a fibrinolysis, they will look different. Okay. Third one. All right. This is a 35-year-old multipara patient, postpartum hemorrhage, hemodynamically unstable, taken to OT for intervention. This is your Rotem. Just making it a little bit bigger to see what's happening here. Any takers for that? Sequence. First of all, anyone wants to try? We'll have one more or two more after this, so we'll be finishing quickly. This is an interesting curve actually. It looks abnormal, but it may not be. Okay, A5 is 27, which is normal. Okay, so no issue with fibrinogen. Now next you jump to extem. You look for the A5 again, 56. pretty good difference, isn't it? So enough platelet there, right? Clotting time is slightly prolonged, and uh, formation time is 63, which is normal, and your firmness is normal. So no issue with platelet or fibrinogen. Okay. But still the clotting time is slightly prolonged. Intensity is high, extensity is also high. So it is probably a deficiency of some coagulation factor. Now the other thing that you look for is your clot lysis. Where is it? ML is 99% here, 99% here, 98% here. So that means there is clot lysis or early clot lysis going on. So that may be the patient may have the patient will need antifibrinolytic or tranexamic acid. I think it's wrongly written there. Maximum lysis is 99%. So this is a um, Rotem curve for early fibrinolysis happening. Okay, or fibrinolysis you can say rather than early fibrinolysis, because the clot lysis ml maximum lysis is 98, 98, 99%. All right. Now the fourth one, this is again a 40-year-old subarachnoid hemorrhage. I have written cardiac bypass, I don't know. 40-year-old subarachnoid hemorrhage patient with Piptem. You can see there is only a flat line. Okay. There is no numbers here. You can see these things when patients are severely coagulopathic. The A5 is not recordable. Clotting time is very, very high in the Piptem. So there is a deficiency of definitely fibrinogen. Now, similar thing on XTEM, you see the A5 is 14. So the platelet function here is only 14 because A5 is 0 and A5 here is 14. That's again not adequate. So probably there is low platelet and also low fibrinogen. Okay. Now you look at the clot lysis, 96%, and on Aptem it is 6%. Okay. So interpretation wise, so critical hypofibrinogenemia, because there is none, you can see there. Markedly prolonged clot initiation and severely reduced clot strength, because your clot formation time is prolonged and your clot formness is only 20 seconds. So these are markedly reduced, which is a function of platelet. So platelet and fibrinogen both are low. Intensity is 300 and A5 is 15 and firmness is 27. Severe intrinsic pathway factor deficiency because the CT is very prolonged in INTEM. So you may need to give other product including FFP. Now APTEM, you see the APTEM clotting time gets corrected from whatever 299 to 132, which means that there is no evidence of hyperfibrinolysis. You can see the lysis is only 6. With the APTEM, this is only 6%. So no significant finding of hyperfibrinolysis. These ml values, which are high in 96% and 99% in XTEM and INTEM, can be artifactual actually, because the patient is very severely deranged in terms of coagulopathy, right? So if there is no clot formation at all, you cannot determine how much clot is being destroyed. Okay, so it can be high in your INTEM and XTEM, but if it is there correcting in the APTEM, that means there is no fibrinolysis happening because the ml is 6% only. Okay, it's very difficult to interpret in this case because the coagulation is severely deranged. There is no clot formation at all to say that the clot is being fibrinolyzed. Okay. So coagulopathy due to hypofibrinolysis or hypofibrinogenemia, uh, and there is associated coagulation factor deficiency. We saw that, and you need to emergently treat these with fibrinogen platelet and FFPs. So the whole thing needs to be done. This is a cardiac surgery patient, 56-year-old post-reduced sternotomy AVR and CABG. Drain output is 400 ml in first hour. Okay, now interpretation. FIPTEM channel, A5 is 21, normal. A5 is 57, normal. So platelet and fibrinogen functions are good. In INTEM, clotting time is 150, again normal. So there is no factor deficiency. In HEPTEM, right? This is a HEPTEM. You can see that the clotting time in HEPTEM and INTEM are same. Okay, that means no problem with heparin. Okay, so what you have is good fibrinogen, normal clot initiation and propagation. INTEM slightly shorter, so there is no issue with coagulation factor. HEPTEM similar to INTEM, so no evidence of residual heparin effect. So all of the things are normal here. That means the patient is bleeding not because of coagulation abnormality, rather than it is because possibly a surgical cause, because you can see most of the things are normal. Okay, except for the maximal lysis in the heptem channel, which is 9%. You can think of giving some fibrinolysis antifibrinolytic like a tranexamic acid, 9 to 10% you can think of, but again not significant. So this is more of a surgical bleeding. There is no abnormality in the rotum. So normal fibrinogen, normal platelet, normal coagulation factor, and very minimal of fibrinolysis. Last one, heparin effect or heparin-protamine effect. So you can see this one, post-cardiac surgery with ongoing bleeding after protamine administration. So what's happening here is, this is again a tricky one. The first channel is 15, A5 is 13, just normal. A5 is 48 in XTEM, so difference is quite a bit. So good platelet and good fibrinogen. Clot lysis is 0.4%, so no significant clot lysis happening. In here, the INTEM, here the clotting time is prolonged, and in the HEPTEM, even if you neutralize the heparin, still the clotting time is prolonged. Can you see this? 268 and 369. So if it would have been because of heparin, then this would have been corrected. The 268 here should have been 100, normal, like 150 or less, if it is because of heparin. Okay, now the patient is being given protamine. This can be due to protamine effect. All right, how do you know? Clotting time in INTEM does not get corrected in HEPTEM. That means if you, even if you take away the effect of heparin, still the clotting time is prolonged in HEPTEM. What can do this is protamine. So this is protamine effect. Okay, what do you mean by that? So you will have prolonged clotting time both in INTEM and HEPTEM. Even if you neutralize the effect of heparin, still the clotting time is prolonged, and this can only be explained by excess of protamine. So again, interpreting the same thing, adequate fibrinogen we talked about 13, and here it was 48. So adequate fibrinogen, adequate platelet intensity here is prolonged, markedly prolonged. Intrinsic pathway clotting factor problem suggests either heparin effect or anticoagulation or some intrinsic factor defect are there. We don't know. Intrinsic pathway defect we can only suggest from here. But in HEPTEM, when you neutralize the heparin, still the clotting time is prolonged. CT remains prolonged, It is not corrected by heparinase, making significant heparin effect unlikely, suggests that coagulation factor deficiency or a oral anticoagulant or other anticoagulation related impairment. So if the patient is on DOAC also, you will find this finding. If the patient has got a excess of protamine, which is again on excess, is an anticoagulant, you can find this finding. It's important, right? Okay. So this is good normal clot strength and fibrinogen level with isolated prolonged CT in intem and heptem. Patterns suggest mild anticoagulation factor deficiency or anticoagulant effect rather than bleeding due to clot strength problem. So protamine excess. So basically, this is a summary of interpretation of the Rotem. So if the extem CT is prolonged, you have factor deficiency, you treat them with FFP or prothrombin complex. If the FIFTEM A5 is prolonged, then you have fibrinogen deficiency, you treat with fibrinogen or fibrinogen concentrate or cryoprecipitate. If you have platelet issues, when both FIPTEM and XTEM are prolonged and the difference is less than 20, like the XTEM A5 should be, the difference between both of them should be less than 20. That means you have both platelet and fibrinogen deficiency. But suppose the FIPTEM A5 is normal and the A5 in XTEM is abnormal, like low, the difference is less than 20. That means you have an additional platelet issue. Fibrinolysis, you look at XTEM and EPTEM, compare the curves, and if there is a clot lysis which is more than, take a number, 10%. In my practice, it is 5%. But if it is more than 10%, then it is due to fibrinolysis. You give tranexamic acid. And if it is because of heparin, you look at the heptem channel. So usually this is a clue. If you get a heptem channel in the rotem, because usually heptem is not there in the rotem. We have 4 channels and usually they are fiftem, extem, intem and eptem. These are the 4 things you get. But if there is a heptem, that means there is a problem, possibly because of heparin. That's why the channel is there. So even if you can't understand, think about heparin excess. Okay. So if there is heparin excess, the clotting time will be abnormal in intem and possibly in extem, but they get corrected in heptem because you neutralize the heparin. So in that case, you know that this is because of heparin. So you give Rotem to correct it. So this is the basics of Rotem. You need to understand this. I think if you memorize this table and try to interpret the picture depending on this table, it will be easier for you. But again, we will be touching about this repeatedly in our course and in the CBS and CCS multiple times, so that at least you get prepared for the exam to answer the questions. I'm happy to take any other questions if you guys have. Otherwise, I'll conclude here. Thank you.